Welcome to the Virtual Lung Cancer Summit, sponsored by Johns Hopkins University School of Medicine on Oncology Care Live. My name is Peter Bach, and you are tuned in to a live session called Recent Advances in Lung Cancer Screening, Risk Assessment, Imaging, and Early Diagnosis. What is ready for prime time? I'm an attending physician at Memorial Sloan Kettering Cancer Center. My main research interests cover healthcare policy, racial disparities in cancer care quality, and lung cancer epidemiology. Before we get started, I would like to remind you in the audience that I will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. I'm going to talk about low-dose CT screening, so please direct your attention to the slides. When you think about screening, and you think about the way that research influences practice, particularly in the area of preventive services, but this cuts across all issues of interventions in healthcare, remember that the goal of clinical research is to predict the future. That's not the way that things are usually characterized, but nevertheless, if a study is conducted and has certain results, the most important question one can ask about that study is, how does it let me know what will happen to the next patient who receives the therapy, the treatment, or in this case, the test that was conducted in the study. So today I'm going to cover the area of low-dose CT screening. I'm going to focus particularly on an evidence review and a set of practice guidelines that were developed by the organizations as listed here. The evidence review was a 4-society collaboration between the American Cancer Society, the American College of Chest Physicians, the American Society for Clinical Oncology, and the National Comprehensive Cancer Network. The ACCP and ASCO clinical practice guidelines that emerged from this effort I'm also going to talk about. Those are for lung cancer screening with low-dose CT, and they've also been endorsed by the ATS, or American Thoracic Society. I'm going to touch on other clinical practice guidelines for lung cancer screening and describe some of the similarities and differences. And I'm also going to talk about the updated evidence on the impact of low-dose CT screening on outcomes since the time the guidelines were developed. Excuse me. First, the multi-society evidence review. All systematic reviews, similar to clinical trials that are well designed, begin with a set of important questions that the review is designed to answer. These are often referred to as PICO questions that address the population, the intervention, the comparator, and the outcomes that the questions are supposed to ask. Amongst these PICO questions, the questions that were asked about CT screening for lung cancer were, what are the potential benefits within this context? What are the potential harms? Which groups are likely to benefit or alternatively not? And in which settings is CT screening likely to be effective? We reviewed the literature comprehensively, focusing only on English language publications. The various databases listed on the slide are the ones we queried to find primary studies looking at LDCT screening that could address these listed questions. We also took a number of other standard steps in a systematic review. When we retrieved articles that we thought were potentially important, we reviewed their reference lists to see if there were studies that we had missed during our first pass through these major databases. We included certain studies to help inform the answers to our questions. For endpoints involving whether or not CT screening affected mortality, such as did it decrease the risk a person would die of lung cancer or decrease the risk they would die of any cause, we looked only at randomized controlled trials, where the randomized intervention was CT screening and where the comparator group or control was either no screening or screening with a technology that's ineffective, such as chest x-ray. For other important events, such as the harms and what groups could possibly benefit, we looked at across studies, and both not only in the arm of the CT randomized trials, where everyone got screened in that arm, and also in many of the studies that were conducted where every individual was screened, often called single-arm studies, observational studies, or cohort studies. We excluded studies that looked at population screened for risk factors other than smoking exposure, for example, occupational exposure to asbestos being the entry criterion, studies that were not in English, Studies that were meta-analyses of other studies, in other words, studies that combine data from other studies that have been conducted and published, and case series studies, such as studies where only certain groups of patients who were found in a screening program were studied or analyzed. This flow diagram describes which studies we included. Across all the studies we retrieved, and there were hundreds and hundreds of them, we found only 21 studies of CT screening that informed answers to our questions. They included 8 randomized controlled trials that looked at the endpoint lung cancer mortality, and 13 cohort studies of individuals who all were screened with no comparison group. We pulled 7 additional studies not included in this group to look at the impact of CT screening on smoking cessation outcomes. That included 2 randomized trials and 5 cohort studies. Shown on the right-hand side of this slide is the retrieval approach, which you can look at. The key findings is that we had hundreds of studies up front, and various studies were excluded and included for the reasons listed. The first question involved the potential benefits of CT screening. Based on 3 randomized trials listed here, we concluded that there was evidence of overall reduction in lung cancer mortality due to screening. I'll show you how we reached that conclusion in a second. But to review, the first screening trial, first randomized trial that was relevant, was something called the National Lung Screening Trial, a large study conducted by the National Cancer Institute and the American College of Radiology Imaging Network. In the NLST, there was a 0.33% absolute decrease in the risk of lung cancer death amongst individuals who had CT screening instead of being in the comparator group, which in this case was chest X-ray screening. That is the same mathematically as saying 3 deaths from lung cancer were avoided for every 1,000 people screened. Statistically, that's referred to as a relative benefit of 0.80 in this context, and the confidence bound goes from about a 0.73 to 0.93, a highly statistically significant reduction in the risk of deaths from lung cancer. In that study, there was no statistical difference in the risks or likelihood of deaths from causes other than lung cancer between the individuals who were screened with CT and those screened with chest X-ray. That's a point I will return to, but it is important to distinguish between that result and what was misreported in some outlets, which was that CT screening appeared to reduce the risk of death from all causes. That's not true in this study. What this study showed was a reduction in the risk of death from lung cancer. All other causes of death, there was no evidence of a decrease through CT screening, not in cardiovascular disease, emphysema, or other causes of death often referred to when people think about screening the chest for disease. 2 other randomized trials were included in this analysis. They are referred to as the Dante trial, an Italian trial, and the DLCST trial, a Danish trial. Those trials are smaller and have somewhat less follow-up, but neither one showed any difference between CT screening and the control group in either the risk of lung cancer death, or lung cancer mortality, or other cause mortality. Here are those same 2 sets of results shown using meta-analytic combinations of the data. The top box lists the 3 studies, Dante, DLCST, and the NLST, looking at the impact of screening, comparing CT screening to control, on the risk of death from lung cancer. Looking all the way to the right in the upper grouping, you can see this combined data leads to a diamond, this big diamond, that's approximately in the same place as the relative risk estimate for NLST, meaning that even combining the data from all 3 studies suggests that CT screening does reduce the risk of lung cancer, death from lung cancer, even including these 2 studies that didn't show an effect. Again, on this other point, with other cause mortality, causes of death other than lung cancer, there is no impact of CT screening on causes of death from other than lung cancer, as shown in any of the 3 studies or the 3 studies combined together. Here, the relative risk estimate is 0.99, basically equal to 1.0. No evidence that screening prevents deaths from other causes like cardiovascular disease or emphysema. It is frequently being advertised as beneficial on those endpoints, which is why I emphasize it so much. We also ask questions about the potential harms of CT screening. Shown on this bar chart are the frequencies with which individuals who, when they are screened, have nodules detected during the CT screening process. Each study we analyzed is listed here, and the height, or in this case, the width of the bars, reflects two pieces of information: the total number of what are called false positives, and then also the ratio of benign nodules to malignant nodules amongst those that are detected, where the small part of the first part of each bar is the number of malignant nodules, and the larger gray one is the benign nodules. You can see a couple of things on this graph. One is the very consistent finding that most nodules are in the gray category rather than the black category, meaning most nodules are benign that are found through CT screening. Another being that malignant nodules are consistently found across all of these studies. And another being is that there is substantial variability between studies in the frequency of the detection of nodules. Now, please note that this graph on the x-axis is not scaled 0 to 100, but instead 0 to about 60, and then there's a break point. So the highest frequency of false positives on this graph is in the order of 50%, not as it would look if we're fully scaled some higher number. We actually combined the data from these studies using a meta-analytic technique and came up with a pooled estimate of about 20%, weighting these studies for their study features and sample size, meaning you should expect, and patients could be told, that about 1 in 5 patients who are screened for lung cancer will have an abnormality or a nodule detected which requires some sort of follow-up. Most of those nodules, about 95% overall, are not malignant. Questions arise about whether or not that is a feature of the first round of screening, and after you sort of get to know what a patient's chest CT looks like, if the frequency of nodule detection falls. This is a graph of the frequency of nodule detection over time in each of the studies we analyzed for those that had multiple rounds of screening separately reported. And you can see a general pattern downwards with some support of this notion that for an individual patient, if they come in the next year, the likelihood that they have a nodule that would be new and potentially a false positive is somewhat lower than the likelihood that they have a nodule on the first round. But please note, the alternative way of looking at this is that, in fact, it's quite likely that even in subsequent scans, people will have nodules. They're not all in the first round, if you will. Now, having a nodule detected is a potential harm. It causes anxiety, perhaps. It causes follow-up testing. But a major concern is actually the frequency with which nodules lead to biopsies and other invasive procedures. One concern, for example, might be that many of these patients who have benign nodules undergo interventions, transthoracic needle biopsies and bronchoscopies and things like that, which are invasive and uncomfortable and carry risks. An alternative would be that we're pretty good, and the doctors in these various studies are pretty good at selecting which patients to biopsy. This graph speaks to that issue. Please note again that the x-axis only goes to 8%, not to 100. So these are relatively low numbers. And here again are the number of patients undergoing a biopsy or procedure in each of these studies. And you can see it ranges in the order of about 2 to 4%. And here you'll notice a reversal. The overwhelming trend is that most, but not all of the nodules that were biopsied in these studies were malignant. So we can say with some confidence that through the management protocols in these different studies, most of the patients who underwent biopsy actually had malignant disease. Smoking cessation, and specifically whether or not participation in a CT screening program would increase the likelihood that an individual would stop smoking, or alternatively increase the potency or effectiveness of a smoking cessation program by marrying it to a CT screening program, is a question of particular interest to us because of the important question of whether or not smoking cessation programs should be part of a CT screening program or not. Now, we ask this question even though there's no doubt that smoking cessation programs are in and of themselves effective, and there's also certainly no doubt that the most important thing that smokers can do for their health is stop smoking. But we are asking a very narrow and important question in terms of CT screening guidelines. If we could conclude that CT screening itself or married to a smoking cessation program had an impact on smoking cessation, which would lead us to recommend conclusion of these programs in CT screening programs. We did not find a lot of evidence. The evidence was weak and varied, but the overall finding was that in CT screening programs and randomized trials, the inclusion of smoking cessation was no more effective in the context of a patient being screened versus not, meaning there's no evidence that the two are synergistic. At best, they're just additive. We looked at other potential harms of CT screening, some of which are listed here. For example, in the NLST, which had the best data on this point, the frequency of complications of diagnostic procedures was a very important issue. How often would, for example, a patient have a major complication from a transthoracic needle biopsy or bronchoscopy? Per 10,000 individuals screened by low-dose CT, there were 3.4 deaths from which appeared to be linked to a diagnostic procedure. It's a non-trivial number, but it's relatively low compared to the number of deaths from lung cancer prevented in the NLST, which was 87. In other words, about 20 times as many deaths from lung cancer were prevented through screening compared to the number of deaths that could have been caused by diagnostic procedures that were triggered by CT. The timing of those two things is not lined up. Those deaths from diagnostic procedures occurred up front, and the benefits took about 6 years to accrue in the NLST. There are also 33 major complications per 10,000 individuals screened. In other words, about 10 times as many major complications, pneumothoraces, bleeding, and things like that. But these did not lead to death. The rate following lung cancer resection of death was 1% in 60 days. And this number is important for several reasons. First, it's an extraordinarily low rate that found in these studies. 1% in 60 days is far lower than the national average of what's about 3% to 4% following lung cancer resection, and that rate is actually usually estimated within 30 days. The 30-day and the 60-day rates are often quite similar, although there are a few more deaths in the 60 days. So the death rate following lung resection in the NLST trial was something on the order of 1/3 to 1/4 of what is seen nationwide. Some of this is likely due to the fact that CT screening is finding smaller nodules than those nodules that usually lead to operation, and thus the operations might be simpler and less invasive. But a concern that has been widely discussed and that influenced our thinking in these guidelines was that this may be a non-representative rate, meaning that the benefits of CT screening weighed against the harms may be out of kilter in the NLST compared to what would be seen in routine practice. Here's an example where the additional harm of CT screening, which would be the additional deaths from lung cancer resection, if they follow the national average, would be substantial compared to what was seen in the NLST, and that would mitigate against the potential benefits of CT screening. Radiation harms are another important concern. There are very poor primary data on the impact of radiation on things like cancer risk, life expectancy, and disease incidence, but there are some. Most are extrapolations of high radiation exposure experiences like the bombings in Japan during the war. From these, there are some models that can be used for extrapolating, and the important conclusion here is that the harms from the radiation due to CT screening, including not only the screening, but those follow-up tests that were triggered by abnormalities in about the rates that were seen in the NLST, would cause about 1/10 as much harm as the size of the benefit seen in the NLST. And those harms would take years and years to accumulate. So we did not, if you will, the take-home on the radiation is that although it's difficult to estimate, it's quite unlikely that the amount of harm from the radiation comes anywhere close to the potential benefit, and it is largely an ignorable phenomenon, although that is only in individuals such as those who are high risk in the NLST. That would not be the case when you get to screening individuals who are younger or at lower risk of lung cancer, a point I will circle back to in a minute. Overdiagnosis, the detection of lung cancers which were unlikely to cause disease or morbidity during an individual's lifetime through screening, is clearly present, as it has been in every study of lung cancer screening, as well, using both chest X-ray and CT, and as it is in essentially all cancer screening contexts. It's not ignorable, but it's difficult to estimate, and it's very difficult to go from identifying that some extra proportion of individuals are diagnosed with lung cancer to figuring out what the aggregate harm is. One important note, those studies or those analyses which I showed earlier showing the frequency of false positives and the ratio of malignant to benign conditions, please remember that these overdiagnosed lung cancers are ones where the patient is actually worse off because you have found them, and then you treat them for something that they need not be treated for. Those overdiagnosed lung cancers still appeared malignant on biopsy, and they would have fallen into that category of cancers that we'd be glad we detected. And so some of those cancers are actually in that bucket of overdiagnosis. And as I mentioned, in terms of harms, it's unclear. The other side of smoking is from cessation could be augmented. What's unclear is this other direction. Could it be that if somebody has a clean CT, that will cause them to continue to smoke or reduce their incentive to quit? It's not clear from the literature. It's not clear from the literature what the quality of life impacts are of screening. And cost effectiveness has been published a number of times. The results are all over the map, from a few $1,000s per quality adjusted life year to a few million. There are no sort of valid analyses from which we can base much of our conclusions. There is an upcoming cost effectiveness analysis coming out of the NLST study group, is what I understand, although I have not seen it. The next question is in which groups and settings should we see a benefit? The data support this first bullet. The high-risk smokers in the National Lung Screening Trial. That's the group in which, in a randomized context, there was a reduction in death from lung cancer. Here are the criteria. Those are individuals aged 55 to 74 with a greater than or equal to 30 pack years of smoking. And if they have quit smoking, they have quit within the past 15 years prior to study entry. This is the only group in which a benefit has been seen, the only group in which there is evidence supporting a benefit of CT screening in terms of a reduction in death from lung cancer. It is also the only group in our estimation where the risk is high enough, and I'll walk through that in a second, that the benefits are quite likely to outweigh some of the harms I've listed, such as radiation exposure, false positives, unnecessary biopsies, and complications from them. Despite that general statement about the group in the NLST, it is clear, and I will show this in a moment, that within subgroups of individuals in the NLST, such as those at higher or lower risk even within that band, that the calculus, the risk-benefit trade-off, probably varies. But it's not clear, and we have no data to date to determine how that risk-benefit trade-off would actually look. It is important, and I've alluded to it already in terms of reference to the low lung cancer low mortality rate following lung cancer resection, that these studies were conducted in atypical settings. Most were large academic centers. Most actually were NCI-designated cancer centers. The compliance in the study, meaning for individuals who were screened the first time, the proportion who came back and were screened the next year and the year after that, was extraordinarily high, north of 90% across most settings and through to the 3 years, something that is really not seen in routine screening for any disease that I have seen in sort of population-based literature. And the doctors, and this is speculation in this case, involved in the study had substantially more expertise, experience, and education around management of findings from CT screening than an average doctor. I say that not because those doctors are at specialty centers, but rather because those doctors were involved in the trial. And so they were particularly attentive, or one could surmise that they'd be particularly attentive to the issues and particularly attentive to attenuating the possible harms of CT screening in that context. These 4 bulleted items are unusual and do not characterize healthcare in general. And these are all things that should give you concerns, or certainly gave us concerns, that the findings from the NLST may not generalize well, meaning that we probably are unlikely to see the magnitude of the benefit that was seen in the trial when CT screening is conducted, if you will, in the real world, in places that aren't large academic centers or maybe not are NCI designated, with incomplete follow-up and compliance, and with doctors who might, in some cases, be less attuned to the conservative management of findings. This leads us to the multi-society guideline statement. Recommendation number 1. For smokers and former smokers who are age 55 to 74 and have smoked for 30 pack years or more and either continue to smoke or have quit within the past 15 years, here's the recommendation. We suggest that annual screening with low-dose CT should be offered over both annual screening with chest radiograph or no screening, but only in settings that can deliver the comprehensive care provided to NLST participants. The grade of this recommendation is 2B. I'll come back to that in a moment. This classification and grading, 2B, is based on a system called GRADE. It's a system that has been widely accepted in the development of practice guidelines, and that grading, that 2-part grading between the letter and the number, convey the strength and contemplation and perspective of the expert panel that reviewed the evidence and developed the guidelines. Let me walk you through this. So the letter grade refers to the quality of the evidence. And here are the 4 categories, A through D, listed on this slide. Where A, for example, is high quality evidence where further research is very unlikely to change our confidence in the estimate of the effect. We graded the evidence supporting CT screening as moderate quality. Further research is likely to have an important impact on our confidence in the estimate of the effect, where the estimate of the effect refers both to the estimate of the beneficial effect, reducing the death from lung cancer, but also the harmful effects, such as false positives, deaths following lung cancer resection, complications from following invasive procedures. We based this moderate grade on there being a reasonably high quality evidence for benefits, but very low quality for harms. And I've shown you the data that inform both of those things. Going to the bottom of the slide, the strength of the recommendation, different from the evidence, gets a number grade. There are only 2 choices. 1, it's a strong recommendation, or 2, it's a weak recommendation. And the rules of grade and the reasonableness standard for counseling of patients about diagnostic tests, or in this case screening tests, supports this being a weak recommendation. And the reason is we don't recommend it strongly because we believe that the trade-off between risks and benefits are in many cases too close to call for individuals and in different care settings. And I'm going to walk you through some of those. And that another way of putting this is that some individuals who fit the NLST entry criteria may value the potential benefits more, others may be concerned about the risks more, and it would be a reasonable decision in either direction. Recommendation 2, which I apologize, I think it didn't show on the slide, but recommendation 2 from the group was to not screen individuals who do not fit the NLST entry criteria. In other words, who are not age 55 to 74 and have not smoked for 30 pack years or more and have quit and if they've quit for more than 15 years. And we rated this recommendation 2C. Again, walking through the evidence, C, there was low quality evidence informing this decision. There's further research regarding these individuals who are lower risk or not like those in the NLST is very likely to have an important impact on our confidence in the estimate of the effect and is likely to change the estimate. That's a reasonable conclusion. There's no evidence right now in these groups that tells us about the size of the benefits or the harms, really. So if we had more research, we're quite likely to have a different conclusion. And in terms of the strength of the recommendation, again, it's a weak recommendation. The trade-off between risks and benefits are too close to call. Some individuals value benefits more, others risk more. And there's undoubtedly differences in this group outside of those in the NLST, differences by lung cancer risk and other health factors, but no data on this. So one of the questions would be, why the NLST entry criteria? Why not these other groups? And does that make sense scientifically? And I think the answer to that question really is, it makes as much sense, it makes substantially more sense than making up your own criteria. Now, that certainly doesn't suggest that in designing the studies, the investigators had a clear view of exactly which groups would benefit or not. It was designed to meet the intersection of having individuals with high enough risk that they could benefit and adequate sample size. But nevertheless, it's a good starting point. It is quite likely that through further research and also some modeling efforts that are being undertaken right now by an NCI-funded group called the CISNET group, that through that process we will identify a different group of individuals who are most likely to benefit from screening. But today, these are the best data. I would emphasize that the group that might be recommended, that might be optimal for screening, could look like the NLST group, could be a subset of the NLST group, or could be broader or only partially overlapping. We included a number of guideline remarks: that counseling should include the trade-off of potential benefits and harms, that CT screening should only be conducted in multidisciplinary settings like the NLST, that a registry should be added to address many of the unanswered questions such as harms, complications, frequency of nodule detection, that quality metrics should be developed, that CT screening is not a substitute for smoking cessation. That's different from saying that smoking cessation programs should be included in CT screening programs. Smoking cessation is valuable, and those programs, if they're well conducted, are effective. But we do not think it's a criterion of CT screening programs that they include it because of the evidence I've shown you. And that it's important for everyone to know that the most effective frequency and the duration is not known. The NLST and most of these other trials look at annual screening for differing periods of time. One would hope that by the time 3 years is up from today, individuals will have better guidance on whether or not annual screening is an appropriate thing to continue. There are a number of other practice guidelines listed on this slide. The one I've mentioned is in the first row, the American College of Chest Physicians ASCO and ATS statement. The type of statement is an evidence-based guideline. It suggests that the screening be offered in the NLST-like subjects, and apologize for the formatting here, but it's pretty legible still. And specifically that other individuals not like those in the NLST should not be screened. This was based on a systematic review, a meta-analysis, and grading of evidence. Next is the American Cancer Society, largely agreeing with this recommendation. That's an interim guidance. The American Cancer Society has not come out with a final. Then there's the American Lung Association, which again has a guidance, not a guideline. Again, recommends this group for screening, but not others. There's the National Comprehensive Cancer Network, which follows a consensus and voting process. And in their consensus guidelines, they recommend not only the NLST-like individuals be screened, but also individuals who were not eligible for the NCCN and have not been studied in terms of efficacy or harm, including individuals whose risk is elevated by occupational exposures and some other factors. The method for concluding this and the type of literature that was used to support it was not specified. ISLAC, an international organization for lung cancer study, is sort of in line with the statement that the NLST-like individuals could be appropriate to discuss with the potential screening. And then again, AATS, the American Association of Thoracic Society, has guidelines where again they recommend the NLST individuals be screened, and also some other individuals. And again, their methods and their rationale is not specified. That brings us to earlier in this year, in March 2012. There is now new data, and this emphasizes, if you will, the value of our B grade and our 2 recommendation for CT screening. As we noted, there was some possibility, in fact, we thought it was quite likely that our estimates of the benefit of CT screening would change as new data emerged. Shown here is meta-analyses including more data, including the MILD trial and another Italian trial of randomized CT screening versus control, combined both for death from lung cancer on the left-hand side and then sadly mislabeled death from other causes on the, oh no, I'm sorry, let me retract that. These are both analyses of death from lung cancer and whether or not CT screening prevents it, using two different meta-analytic techniques called random effects and fixed effects. Without digressing, these allow sort of a liberal and a somewhat conservative assumption about how similar these studies are that you're trying to combine. Importantly, in both cases, the inclusion of more data seems to push the perceived benefit of CT screening towards the null, meaning that the inclusion of this other study, the Mills trial, is lessening our estimate of the effect of the benefit of CT screening. In fact, one of these, the random effects model, actually causes CT screening across the studies to appear to be ineffective. This is the combination of the data on death from causes other than lung cancer, and similar to the prior report and the data I've discussed, there's no evidence, including this other data as well, that CT screening prevents death from causes other than lung cancer. Why would these results be so different? Once you combine these data and come up with a new estimate, in this case, in one of the methods suggests CT screening doesn't prevent death from lung cancer, the question you have to ask is, why is this? Why is this, the result from the NLST, not being replicated in these other studies? There could be a number of reasons, and some could relate to both this design of the study as well as from the features of the places where the study were conducted. There is different periods of follow-up. Most of these studies have fewer years, so maybe it takes longer for the benefit that was seen in the NLST to emerge. There could be statistical flukes, chance essentially, that the NLST had by chance an overestimate of the size of the benefit. And the other side of the statistical fluke is that there's random noise in these smaller studies that, if they were larger and over time, would start to show what the NLST showed. We don't know. The intervention had a different intensity. As I mentioned, in the NLST, there was an extraordinarily high degree of follow-up for individuals subsequent to their initial scan, and also presumably very good follow-up towards therapies for patients with nodules. If there were inadequate rounds of screening in the other studies, or there were not enough early lung cancers found, another explanation for screening's ineffectiveness in these other studies, that could explain the differing results. There could be basic differences in care quality. Now here, to address these questions, here are the results and the features of the 4 different studies that combined don't appear to show as much of a benefit as the NLST did itself. There is somewhat more follow-up in the first row for the NLST. The organization and adherence in the centers of excellence that characterize the NLST may or may not be present in the other studies. When we made this slide, we didn't have that information. The control arm is actually different. Only the NLST had a chest X-ray control arm. Now, the other studies had usual care. Now, to hypothesize that that was the reason for this difference, you would have to assume that chest X-ray caused harm, caused more people to die of lung cancer, which would make CT screening look beneficial when in fact it wasn't. That's a highly unlikely occurrence. There are multiple randomized trials now of chest X-ray screening versus usual care. None show a benefit, including the very large PLCO trial that was recently published. And in the subgroup eligible for the NLST, there was no evidence that chest X-ray caused harm or increased the risk of lung cancer death. The number of rounds of screening actually weighs towards these other studies that appear to be negative. They each had 5 rounds of screening, although the level of adherence was low in most of them. There is evidence that all of these studies find the additional cancers that CT screening must find in order to provide benefit. There's the example of the comparison of the number of extra lung cancer cases found in the red CT group versus the blue control group in each of the different arms. In fact, the gap in the case retrieval, case ascertainment among screened versus not screened appears to be larger in the MILD and the DLCST trial than in the NLST trial. In other words, screening is working in the sense that it's finding additional early cancers. We don't have data like this for Dante, the other trial. Then there's the question of risk. So I'm going to change gears to talk about this important issue. When looking at CT screening and when considering which individuals to screen, the important question is, what is the person's risk that they will die of lung cancer absent screening. Why do we care about this? Well, first of all, because lung cancer risk varies. Young people are less likely than old people. Heavy smokers are more likely than light smokers. It varies. Next, it's predictable. The truth is that for all of us, our risks of all sorts of diseases vary, but in many cases, we don't have any insight into what those risks are. And so even if it varies, because it's not predictable, it's not particularly useful clinically. But in this case, the risk is variable and predictable, and the risk of the disease is a key component of whether screening could help. At the limit, somebody who has zero risk of developing a disease cannot benefit from a screening test for it. It's a logical thing. And in fact, both the AATS and the NCCN, I'm sorry this got clipped, have non-studied groups recommended based on risk level. Here's a graph showing this important phenomenon. This is for the NLST trial. Across from the lowest risk to the highest risk individuals, you can see the number of lung cancer cases that would be accounted for in the study. It's a somewhat complicated graph, but the two key findings, this is something called a Lorenz curve. It has to do with the distribution of things across groups. The key finding is that if you take the individuals in the NLST who are in the lowest quarter of risk, they don't account for 25% of the lung cancers, even though they account for 25% of the people. They only account for 8%. If you take the people in the highest quartile, although they're only 25% of the people, half of all the lung cancers come from them. So this is the range and the importance of risk. There are different risk models available. Shown on this slide is a summary of those models. One was designed by me and my colleagues and published some time ago based on randomized trial data from the CARROT study. These others listed use differing methods, including other sorts of cohort study methods and case control methods. They have these following features, which are shown here. Some of this is statistical mumbo-jumbo. The important finding in all this is that all of the studies show and all the models appear to be able to predict the risk that an individual will have lung cancer or develop lung cancer or die of lung cancer, depending on what the model is designed to do, with some degree of accuracy. Some perform slightly better in some contexts or less well, but the basic idea is that there's risk prediction. These are the variables included in the model, and they share many of the features listed on the top part of the slide in terms of smoking, but other things are not included in all of the models. Here's a web shot actually of the tool that's on the website at my institution, Memorial Sloan Kettering. This is actually the model that we developed that I mentioned earlier. It's not the only model, but it is available. I'm not promoting it. I'm just trying to explain where the science is on this. This is an individual tool. There's one from MD Anderson as well. I'll show that to you in a second. No, I won't. I apologize, but there are different tools where you can log on and input a particular patient's characteristics, and it will produce a quantitative estimate of the risk of lung cancer. This individual who's 70 and smoked for 55 years, a couple of packs a day, has a 10-year risk of developing lung cancer of about 13% if they quit smoking, and about 18% if they continue to smoke. How much does this matter? Shown on this table is a report recently published by Michael Gould and myself showing the risks of lung cancer and the potential benefits of CT screening for different individuals based on their risk profile. The first is a typical participant in the National Lung Screening Trial, a 62-year-old who's currently smokes about a pack and a half a day and has done so for 35 years. The first column shows the likelihood that that individual in 6 years per 1,000 people like him will die of lung cancer if they're not screened. And per 1,000 people, the answer is 19.5 of them will die of lung cancer over 6 years if they're not screened. If they are screened, the number of people who will die of lung cancer is 15.6. This is from the relative risk estimate, or the benefit size in the NLST. So the number of lung cancer deaths averted per 1,000 people over that time period is 3.9, very close to the general estimate from the NLST of about 3 per 1,000. And so the person's needed to be screened, like the NLST showed overall, to prevent one lung cancer death is about 300, or in this case, 256. Now consider a minimally eligible person in the NLST. It would be a 55-year-old former smoker who has smoked, for example, 1 pack per day for 30 years and has just quit. If you take 1,000 women like this one and screen them, and don't screen them, only 4 will die of lung cancer in the next 6 years. If you do screen them, 3.2 will die of lung cancer, meaning you've prevented 0.8 deaths from lung cancer per 1,000 women screened 3 times and followed for 6 years. That equates to 1,236, I believe it's 36, people you would have to screen to prevent 1 lung cancer death that's yet screened 3 times and followed for 6 years. There's a next person is a high-risk participant for the NLST who's even at higher risk than the first entry, and you can see there the contrast, only 82 people like this gentleman, I believe it's a man. Sex is not specified, but sex does not influence the risk of lung cancer. The 70-year-old would be 82 people you'd have to screen to prevent 1 lung cancer death. Now consider that compared to some groups and guidelines offering screening. The NCCN guidelines I previously mentioned recommend screening all the way down to a 55-year-old who smoked a pack a day for only 20 years and who quit 10 years ago, who also has occupational asbestos exposure history. You can go all the way to the right here. 3,180 people would have to be screened 3 times for 6 years to prevent 1 death from lung cancer amongst individuals like this person. So it gives you a sense of how much less efficient screening is as you go into lower risk groups. And then we actually found an ad from a hospital outside of San Francisco called the Sequoia Hospital. They're offering to screen 40-year-old people who have lifetime exposure, very little smoking. Here's a 40-year-old female who's smoked 1 pack per day for 10 years and quit 15 years ago. That only 0.1 per 1,000 women like this will die in the next 6 years of lung cancer. 0.08 per 1,000 will die if they're screened. That equates to 35,000 women like this having to be screened 3 times and followed for 6 years to prevent 1 death from lung cancer. These are complicated data. They involve a number of analyses that are somewhat sophisticated from a statistical perspective. They, if you will, further clarify what kinds of groups should be potentially screened and the risk-benefit trade-off. But as these things are translated to patients and individuals, and we all see this in our clinical practice, the dissemination of this information has been difficult, and it has been clouded to some extent by information that's been promulgated, which is, appears to be fact-based, but is actually not derived from evidence. So here is, if you will, an example or a case in point. These on the left-hand slide, these are the words from the president of a lobbying organization that lobbies for lung cancer screening in Washington, saying that lung cancer screening will prevent half of all the 160,000 deaths from lung cancer each year in the U.S. In other words, half of 160,000 is 80,000. To the right is a simple version of a calculation extrapolated from the NLST. If you take the 8 million people in the NLST, in the U.S. who are like those screened in the NLST and follow through on the math, it'll prevent screening that group as well as the NLST could do, which is better, I think, probably than we can achieve in general practice. It will prevent about 4,400 deaths from lung cancer. There are also ads offering discount coupons without specifying which individuals should be screened. There's also an advertisement from the Sequoia Hospital, the group I mentioned earlier, inviting anyone 40 and over who smoked 100 cigarettes in their lifetime. That's a total of 5 packs with a price. There's coupons from, this is a group in Georgia, offering discounts for individuals and only $100 more to screen a couple. So compared to the evidence and the science and the recommendations that I've tried to walk you through today, I think we're all aware that in the outside world, what customers or consumers or beneficiaries or patients or whatever you want to call them, potential people who have screening, are being told is substantially more rosy and probably somewhat misleading about CT screening and what we know about its benefits. Now, I've received a number of questions. I want to thank you for your attention, but I'd like to try and address them. One of the questions I received has to do with The groups that do not meet the NLST entry criteria, but still patients or individuals who ask to be screened, and whether or not there's a role for chest x-ray. So our recommendation, as well as that of most but not all organizations, is that only individuals who are like the NLST should be screened for lung cancer. The question in front of us is, well, what people with lower risk, is there any benefit to screening them with chest x-ray or screening them with CT? And I think the answer is, for sure not with chest x-ray. It's been shown in multiple randomized trials, depending on how you count, either 3 or 4 randomized trials at this point have shown that chest x-ray screening does not reduce the risk of lung cancer death. So it should not be performed. It is only potentially harmful. It does lead to overdiagnosis and thus excess treatment. The pooled estimate for that is about 25% of lung cancers found through chest x-ray screening are probably overdiagnosed, in the sense that identifying them and treating them will only cause harm and not benefit. We don't know which ones those are, of course. So chest x-ray screening should not be performed. On the question of whether or not CT screening should be performed in these individuals, there are organizations that recommend this. I think it's highly unlikely that individuals who weren't eligible for the NLST would be anywhere close to a level of risk that would justify it. Remember the table I just showed you, that even individuals who were eligible for the NLST were very unlikely, in some cases, the ones at the lower end of risk, to develop lung cancer, and thus very, very unlikely to benefit from CT screening. Those individuals, the calculus, as I referred to it earlier, for the risk-benefit trade-off might be substantially different and unattractive compared to what it is overall. So as you creep down into lower ages, less smoking exposure, you're also creeping into groups that are at lower and lower risk. And as I showed you, at the extreme, screening a 40-year-old who's only smoked for, let's say, 10 years, 1 pack a day, well, that's a substantial amount of smoking for all of us in terms of what we think about. That individual, you'd have to screen 35,000 of them for 3 years and follow them for 6 to prevent 1 lung cancer death. There's no way that that is an appropriate thing that is net beneficial for that patient. There's also no way that that is cost effective, although we haven't talked about cost effectiveness today. The other question I got is if anyone is looking at a potential blood assay or biomarkers for lung cancer. I think the answer to that is yes. I have seen some preliminary data from a number of sources suggesting that there might be tests that could be drawn to look at, for example, evidence, genetic evidence of mutations associated with lung cancer or other epiphenomena associated with the presence of lung cancer. Where those fit in an algorithm for screening is something that is yet to be determined. And in fact, it's early days for any of those methods. There are 2 appealing possibilities. One is that the blood test, if you will, precedes the use of CT, and only the individuals who test positive on the blood test, if you will, put it in crude terms, would be screened. An alternative is it would be used to risk stratify individuals who have suspicious findings on their CT scan. I don't know which way that will go, and actually at this point it's not clear whether or not we have tests that have adequate performance characteristics such that it would justify their place in either arena for CTs for lung cancer screening. I want to thank you very much for your attention. I'd like to thank Boehringer Ingelheim, Genentech, and Daiichi Sankyo for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for our next session, Recent Developments in Targeted Therapy for Non-Small Cell Lung Cancer, with Drs. Gregory Riley and Mark Criss. Thank you for joining me.